Hello, you lovely lot, and welcome to SureenaSpeaks. And today we're going over the ears, the note, and the oropharynx. Quite a short chapter, quite a straightforward chapter, which we like. So let's start off with the ears. So you can get different types of ear conditions. Two main ones that this chapter goes through is Otitis Externa and Otitis Media. Now, anything with the word ot means ear. So remember with aminoglycosides like gentamicin, one of the big side effects it can cause is ototoxicity. So again, ot. Everything ot is to do with ear. In terms of otitis externa, otitis media, we know that if anything ends the word itis, it's to do with inflammation. So otitis externa is inflammation of the ear. More specifically, it's inflammation of meatal skin. Meatal skin is basically just the opening of the ear canal. So how can we treat this? Well, we could use suction, so suction or mopping of the area, which is quite effective. Or patients can use a ribbon gauze dressing or a sponge wick, soak it with corticosteroid eardrops or an astringent such as aluminium acetate solution, and the patient needs to lie down with their affected ear uppermost for 10 minutes, and they'll place either the ribbon gauze or the sponge, they'll place it there for 10 minutes. If there is an infection, then we can give the patient neomycin or cleoquinol. Shouldn't really use it for more than 1 week because excessive use of it can lead to fungal infections or even sensitivity resistance towards it. So we can also use chlorphenical eardrops. Slight weariness with this though is that because these chlorphenical eardrops contain propylene glycol, actually 10% of people are hypersensitive towards it. So if you're ever dispensing it, just make sure to counsel the patient to be aware of any hypersensitivity reactions. If the patient has inflammation and eczema, then you would ideally want to give an anti-infective plus a corticosteroid. Now, as I mentioned before, aminoglycosides can cause ototoxicity. Therefore, it's contraindicated in patients who have a perforated tympanic membrane or a patent grommet. Now, in layman's terms, a perforated tympanic membrane is essentially a rupture of the ear canal, and a grommet is these little tubes that they can put inside the ear to help treat with conditions. So if a patient has any of these two things, then the aminoglycosides are contraindicated. Some specialists, however, will still use that, and they can only use these in patients if a certain criteria is met. So if there is an obvious infection, it should not be used for more than 2 weeks. The patient needs to be counselled on signs of ototoxicity, and a baseline audiometry needs to be performed before treatment. So only if that criteria is met can a specialist still use aminoglycosides in patients with a perforated tympanic membrane or a patent grommet, but in general, those two would be contraindicated in giving someone, in giving someone that is on aminoglycosides. And there's acetic acid, and acetic acid can be used for antifungal and antibacterial conditions of the external ear canal. If, for example, a patient has a boil on the ear, the antibiotic of choice would be flucloxacillin. Why flucloxacillin? Well, if we think back to our infections chapter, majority of the time if there's a skin infection, flucloxacillin is our preferred antibiotic of choice. Then we move on to otitis media, and that's the most common cause for ear pain in children. If the child has had it for more than 72 hours, then usually systemic antibacterial is given. Topical treatments or eardrops containing local anaesthetics tend to be ineffective in otitis media. Now, what if the child gets otitis media with effusion? Well, the other common name for this is glue ear, and around 10% of children get this, and 90% of children with cleft palates get this. So in these cases, systemic antibacterials aren't usually required, and only if the child complains of it for 1 or 2 months would they then be referred to a specialist. Saying that though, unless the child's had it for more than 3 months is usually when treatment would be given. However, If the hearing loss is really severe, if it's affecting the child's learning and development, or the child has Down syndrome or cleft palate, then usually treatment would be given. So chronic otitis media. So opportunistic organisms can present themselves in debris, keratin, necrotic bone in the middle ear. So what can we do? Well, we can cleanse using oral microsuction, or we can do the whole ribbon gauze soaked in corticosteroid eardrops or aluminium acetate astringent, as we mentioned with the Otitis Externa section. We can do all that bit again where you lie down, have the infected ear uppermost. That can be quite effective for any discharging ears or any infection. If there is acute exacerbations of chronic infection, then we might need to use something like amoxicillin. We can use antibacterial ear ointments. And again, if a patient is on aminoglycosides that could cause ototoxicity like gentamicin, then again, don't use them in patients with a perforated tympanic membrane or a patent grommet. And a really good alternative that we could use instead, but it isn't licensed, is using ciprofloxacin or ofloxacin eye drops. So using eye drops for the ear, but that would be an unlicensed use. Now, in terms of removal of earwax, so cerumen is the fancy word for earwax, and it's a protective film, and it should only really be removed if it's affecting a person's hearing or it's interfering with the view of the eardrum. So if it does need to be removed, what can we use? We can use olive oil, almond oil, sodium bicarbonate drops, but this can cause drying of the ear canal. If a person has really hard earwax, then they should use the drops twice a day for several days. And again, lie down with the affected ear uppermost for 5-10 minutes. Now, the nose. So rhinitis is self-limiting. But in terms of nasal allergies, just think about what we give in hay fever. So antihistamines, topical antihistamines, patient might even need topical corticosteroids, or even decongestants if they're really bunged up, but this should only be used for short term. In terms of effectiveness, the order that I would go in is chromoglycate, then topical antihistamines, and then the most effective would be the topical corticosteroids. Now, with hay fever, allergic rhinitis, ideally a patient should start treatment 2 to 3 weeks before the season commences, and then treatment might be continued for months after that. In allergic rhinitis, patient might benefit from topical ipratropium because this can help reduce watery rhinorrhea. Rhinorrhea is essentially diarrhea, but in terms of your nose. So topical ipratropium can help reduce any watery rhinorrhea. Now, I mentioned that corticosteroid nasal preparations are effective. However, situations in that they shouldn't be used include after nasal surgery, if a person has pulmonary TB, and in untreated nasal infections. So in those situations, avoid corticosteroid nasal preparations. And in terms of children using nasal corticosteroid preparations, you need to watch out for their growth because their growth can be affected. And if it is affected, then they need to be referred. In terms of drops versus sprays, nasal sprays. So when instilling drops, it should be done so in the head down position. Head down, that's what it's called, position, where if this is the patient, well, that's their head. Place the head down, and ideally want the nose to be upwards, and then it makes it easy for the drops to go through. But the drops can cause more systemic side effects than nasal sprays, so something to be aware of. Fun fact for the day, the nose produces 1 litre of mucus in 24 hours, and that goes from the oropharynx into the stomach. So think of that what you will. Sodium chloride 0.9% nasal drops or sprays. They can help relieve congestion, and you can even give them to babies, and ideally give it before feeding because then it helps open up their nasal passage. They can breathe a lot more easier, makes feeding a lot easier for them. A very effective method to help with congestion is actually inhaling warm, moist air, especially if it has menthol or eucalyptus in it. It can really, really help patients. What can also help them with any congestion that they might have is sympathomimetics, because this causes a vasoconstriction, which reduces edema. But if a patient is on, say, a monoamine oxidase inhibitor, a MAO, then they should not be given a sympathomimetic because they're at increased risk of a hypertensive crisis. And the problem with sympathomimetic nasal preparations is that once you withdraw from them, you're at a risk of getting rebound congestion. There's ephedrine nasal drops, so ephedrine hydrochloride nasal drops. These are probably the safest sympathomimetic, and they can provide relief for quite a few hours. You also have oxymetazoline and xylometazoline, but these are a bit more potent. And there's no evidence that topical anti-infective nasal preparations are beneficial in rhinitis or sinusitis. In terms of nasal staphylococci, we could give creams containing chlorhexidine and neomycin, such as an Aseptin. That's really effective. Ointments that contain mupirocin should only be reserved for really resistant infections, for example MRSA, and should not be given for more than 7 days. Now, I mentioned ephedrine before. Ephedrine and pseudoephedrine are just an example of medication where you really need to know the legalities behind it, because it can be sold over the counter in cold and cough remedy products. However, ephedrine you cannot give out more than 180 milligrams, or a pseudoephedrine more than 720 milligrams in one transaction. So ephedrine 180, pseudoephedrine 720. Just remember, pseudoephedrine has more letters in it, so it's the one that is the bigger amount, it's the 720. And pseudoephedrine is only licensed in children over 6 years old, so you can't sell it for a child under 6 years old. So now on to our oropharynx. So one of the conditions we're going to look at is dry mouth. Now, dry mouth could be due to many different medications. It could also be due to a side effect of medication, particularly those that have antimuscarinic side effects, so antispasmodics, tricyclic antidepressants. It could be caused by medication like diuretics in patients that have had irradiation therapy to their head and neck, or in patients that have damage or disease to their salivary glands. Now, patients that have dry mouth tend to have poor oral hygiene, so they're at more risk of getting, say, oral infections like candidiasis. They can get intolerance to dentures, and they can even get a burning sensation in the mouth. So some of the ways that we can help stimulate saliva is by having frequent small sips of cool drinks. Sucking on sugar-free pastilles or ice can help if the patient has sugar-free gum, or we might need to give them artificial saliva. Something like pilocarpine tablets, that can be used in patients with dry mouth who have undergone radiation therapy for head or neck cancer. So a little bit more on oral hygiene. So lozenges and sprays, there's no evidence that they're effective. And actually, when someone asks me to recommend a lozenges to them, personally, the one that I recommend are Tyrosets, because at least they contain a local anaesthetic, they contain an antibiotic, they help me. So those are ones, that's the one that I usually recommend. But yeah, there's no actual evidence that lozenges help. We also have mouthwashes. Mouthwashes can help with any superficial infections. They should be used frequently and vigorously. Something like saltwater gargle is actually very effective. Or you might need a mouthwash that contains an oxidizing agent like hydrogen peroxide. A really big mouthwash out there, a very popular mouthwash, is chlorhexidine or Corstil. And this is great because it has antiseptic properties. It can help with infections like oral candidiasis. It comes as a mouthwash, a gel, a spray. But with any medication, there's always a risk of some side effects. In the case of chlorhexidine, a big one with them is reversible brown staining of the teeth and the tongue. So just counsel your patients on that. And in very, very severe cases, could even get anaphylaxis or hypersensitivity. Now, in terms of dental caries, fluoride is used in the prophylaxis of dental caries, and topical fluoride on enamel and plaque is actually more important than giving something systemically. Now, a question that they could ask on fluoride is for you to compare the different fluoride content in different areas. So, for example, they may give you the values of the fluoride content in Scotland, England, Northern Ireland, and Wales, and you have to decide, based on those values, which area would need administration of fluoride tablets. And the answer would be the area that has less than 700 micrograms. If it's less than 700 micrograms, it's important that they administer fluoride tablets or drops into their water to provide suitable supplementation. And in children less than 6 months old, or infants less than 6 months old, they don't really need fluoride supplements. Examples of toothpaste that you can get on prescription for dental caries are, for example, our Colgate Durafat 2,800 parts per million or our 5,000 parts per million. And the main counselling with that would be to avoid rinsing the mouth or eating anything within 15 to 30 minutes after putting the paste on. So now we'll talk about oral ulceration and inflammation, and then we'll go on to bacterial, fungal and viral infections. So ulcers, why might a person get an ulcer? Many different reasons. These include trauma, infections, GI disease. But if a person has an ulcer for more than 3 weeks, it's very important that they get referred to rule out oral cancer. Now, we can give the patient saline mouthwash as an effective pain relief. We could give them an antiseptic mouthwash like our chlorhexidine. Could even give them topical corticosteroids, for example, hydrocortisone oral mucosal tablets, which can dissolve next to the ulcer. They're given buccally. Side effect of them though is candidiasis, so just be careful. Or we could give products that contain local anaesthetics, for example, lidocaine. But if you are giving a local anaesthetic, just be aware to tell the patient that if they're using it on the pharynx, obviously local anaesthetics, the way they work is that they numb the area. So try not to eat straight after because that could lead to choking. In terms of inflammation, NSAIDs. So we could give benzodiazepine, so either as a spray or a mouthwash. It can help reduce any discomfort. If you do use the full strength mouthwash though, then it can cause stinging, so it's an idea if the patient dilutes it with water. There's also fluoroprofen, again an NSAID, and this comes as a lozenge to again help with the throat and discomfort. And remember, any products containing salicylic acid should not be used in under 16-year-olds because of the risk of Ray's syndrome. So moving on to infections, so if we start with bacterial infections, if a patient has, for example, gingivitis, then metronidazole or amoxicillin for 3 days can be effective. In the case of recurrent aphthous ulceration, then doxycycline can be effective, but remember, doxycycline, don't give it to under 12-year-olds. In terms of fungal infections usually due to Candida, and it could be patients that are more likely to get fungal infections are those that are on inhaled corticosteroids, those are on cytotoxic, those that have reduced immunity, such as patients that have leukemia, HIV. And please, 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 whenever you dispense, whenever you give out inhaled corticosteroids, your clenomodulite inhalers, always remind the patient to wash and rinse their mouth out after use. So what we could give to patients that do get oral candidiasis, we could give them miconazole gel, which 15-gram tube is available over the counter to the public. We could give them nystatin, but that's prescription only. Or if they're really unresponsive and nothing else is helping, then might need to resort to fluconazole. In terms of denture stomatitis, so patients that wear dentures, they need to clean them regularly. Don't wear them at night time, and it may be an idea to actually put miconazole gel onto the dentures before inserting to help prevent any denture stomatitis. And in terms of chronic hyperplastic candidiasis, patients that get this are at increased risk of malignancy, so a biopsy would be essential, and may even give something like fluconazole. And in terms of viral infections, so if a person gets primary hepatic gingivostomatitis, you would advise them to have a soft diet, adequate fluid, might give them analgesics, benzodiazepine, chlorhexidine mouthwash can help. But in cases of severe hepatic stomatitis, like with everything else that's viral, give acyclovir. So that's ear, nose and throat. And You know those little monkeys, the little see no evil, hear no evil, say no evil? I kind of feel like this chapter is like that because it's like hear no evil, say no evil, smell no evil. But it's quite a quick, straightforward chapter. One of the more nicer chapters, I think. And I hope it's helped you. And if it has, why not give it a thumbs up, give it a like, share with your pharmacy buddies or whoever you think would benefit from this video, and make sure to subscribe for all the latest information. And why not join our Facebook page too? www.facebook.com/SureenaSpeaks. And until next time, good luck with your revision and happy revisings.